Okay, so moving on to our next presenter. So it's Dr. Siping Lo, and he's talking on challenges and solutions in lot-to-lot verification. So Siping is well known to a lot of you and certainly a lot of us at QAP. He's the current APFCB travelling lecturer for the National University Hospital. He also serves as the Senior Consultant and Research Director at the Department of Laboratory Medicine, National University Hospital, Singapore. So welcome, Siping.
Hi, everyone. So thanks, Peter, for the very kind introduction. Just to comment about some of the questions earlier, although it's not my lecture, but if you do have we recently did a study whereby we looked at recalibrating instruments when there is no true error associated with that particular measurement procedure. So for example, there tends to be a thinking that if you keep recalibrating the instrument, you may in fact increase the variability of the instrument or the measuring procedure. And in the simulation that we did, we found that not to be the case, that in fact, if you recalibrate more frequently, you may actually reduce the variability of the measurement procedure. So coming back to the question about if you have a hematology instrument whereby one of the parameters is out and the rest are in, whether you should recalibrate or not, I would say you should proceed to recalibrate because it actually doesn't affect the rest of the parameters that are otherwise in control. So that's that. And then the second comment was that with regards to the patient-based QC and how you implement it in the pediatric hospital, if you come by our workshop tomorrow, we will be very happy to discuss those with you. And you can actually experiment with it yourself using the tool that we are going to introduce tomorrow. So today I'm going to talk about lot-to-lot verification. I'm Siping. I'm glad to be here. I'm from the National University Hospital of Singapore, although I'm originally from Penang, Malaysia. Acknowledgements, I would like to thank the organizers for the kind introduction. The kind introduction as well as the kind invitation. I have no conflict of interest to declare for this particular lecture. So Tony has given a very engaging and illuminating talk earlier, and many of those principles are going to be recurring in this particular lecture as well. So some of these, before we go into discussing lot-to-lot verification as well as the issues associated with lot-to-lot variation, we should perhaps step back and think about how are laboratory results used, or what are the basic tenets of using laboratory results. So laboratory results are produced by hardwares, consumables, as well as reagents. And the majority of the laboratory results are actually used for monitoring and diagnosis. And we tend to think that laboratory results, changes in them, may trigger or result in clinical actions. And therefore, there is importance in trying to maintain the long-term stability of laboratory results, because if we don't maintain the long-term stability of the laboratory results, if a patient is seen by the doctor and is done in the laboratory and there was a shift in the performance, the result would therefore shift upward or downward that may not actually reflect the biological condition of the patient, and therefore it may trigger a spurious or erroneous clinical action. And therefore, there is a need to minimize analytical fluctuation in order to accentuate clinical trends, right? So if you have laboratory results that are fluctuating, mostly because of the instruments, then it would be very difficult to see the biological trend of the patient underlying that, because it would have been overwhelmed by the analytical variation. And one of the sources of that is the lot-to-lot change or variation. So where do sources of lot-to-lot variation come from? It can come from manufacturing batches. For example, the manufacturer may raise antibodies using different batches of cell lines or animals, or it could be produced by different batches of chemicals that can have different purity or contamination and things like that. It could be affected by transportation. So if the transportation is not maintained in a condition that would preserve the integrity of the reagents, that can actually affect the downstream performance when it arrives in our laboratory. Same goes for the storage. So ideally, manufacturing processes, transportation processes, storage, all comply to appropriate relevant standards. And therefore, there is a need for the laboratory to verify that the variation incurred during these processes fall within the clinically acceptable limits. So what are the potential impact of lot-to-lot variation? It could actually affect the analytical system in terms of drift or shift, which we could see it as bias, or it could actually affect imprecision, right? Drift is something that we don't detect very well, but we need to be aware that there may be a cumulative effect over time. So if a reagent lot shifts little bit by little bit, yeah, and each time when we compare two lots, it will fall within our acceptance criteria, and therefore we would accept it. We'll say that it's good to go. But if you accumulate across a few different lots, then the total variation or the total drift may be actually very large. Shift is something usually we emphasize on, so we are looking for a huge jump in results, but that may not always be the case. Imprecision is something we commonly ignore based on the current procedures that we use for lot-to-lot variation. And in fact, when there is a significant lot-to-lot variation or drift or shift, it's often first detected by our clinicians. I personally have had corridor conversations with my clinicians whereby they say, hey, you know what? I noticed that this particular test has been giving me more positive results recently. Has there been a change in the laboratory, or have you noticed that in the laboratory? So this is an example from more than 10 years ago of a positive drift in IGF-1 in one of the automated analyzer. And what you can see is that over time, there had been a positive increase in the number of patients who has above reference limit results, so positive results. Yeah? And you would also notice that the result has also, the number of patients with normal results has also reduced. Okay? And this has happened in 2 different institutions. And this is across 5 years, whereby there is cumulative, small positive drift over time. So this is another way to represent potential impact or biological, clinical impact of either drift or shift in terms of how we use the laboratory data. So this is HbA1c, and what we can see is that if we have a positive bias, it will lead to more false positive rates. Similarly, if we have increased imprecision, it would also lead to increased false positive rates. So people whose HbA1c are otherwise deemed normal, below the diagnostic cutoff, if you have a positive bias, more will become positive and being diagnosed as diabetes. Okay? Similarly, if you have increased imprecision, what will happen is that the distribution will flatten out, becomes lower, but broader. So once it spreads broader, more of them will go across the threshold and become positive. This is another example. This is actually my laboratory data. And it happened in our LC-MS for vitamin D assay. Yeah? So in mass spec assay, when we just used a different methanol lot from the same catalog number, from the same manufacturer, but just different lot. And the lot was produced by a different country when it was given to us. And what we noticed was that you can see the signal was significantly suppressed. Yeah? It went from here all the way down here. And this is methanol. Methanol is something that we use in mass spec laboratory, that we take it for granted. We just assume that it's always the same. We don't think about it as though it is a calibrator or a QC or internal standards. It's just methanol. You would think that it's high purity. right? Manufacturers will claim that it's 99% pure because it's mass spec grade. Yet, what we found was that despite so, even having the same catalog number from the same manufacturer, just because it's a different lot produced by a different country, there are contaminations within which that significantly suppressed our signal, almost to the effect of being undetectable. Yeah? So what are the challenges with lot-to-lot verification? So first of all is the definition of lot. You'd be surprised that most of us don't actually use the same language or the same definition across different bodies, from the user, from the regulator, as well as from the manufacturing side. And because of that, we don't have the same understanding of what constitutes a lot. For us, most of the time we consider that if the lot number changes, then it's a new lot. From the manufacturer's side, that may not always be the case. They could change the ingredients or the manufacturing process, or indeed the manufacturing plant within the same lot, and yet they may still call it, they may still call it the same lot instead of a different lot. And that may actually affect the performance downstream. The definition of acceptable performance specification between regulators, the manufacturers, as well as the users are again varied, and therefore, what the manufacturer may claim as acceptable may not be what we think is acceptable clinically, and again, may not be the same as the regulators. And therefore, we may have a situation whereby the manufacturer said, hey, this lot has gone through my internal processes, we've checked it, it works well, it's great, we pass it on to you, and then now you're telling me that it's not within your specification, you're not happy with it, and you want us to change it or you want us to do something about it. But there is nothing they can do about it because it has passed their criteria. So therefore, if there is this discordance in definition of acceptable performance specification, then it becomes very difficult for us to actually have a harmonized way of accepting and using the different reagent lots. The commutability of the material that we use to verify reagent lot can also challenge our verification process. Indeed, if we use a non-commutable material, we may find false positive or false negative reagent lot verification performance. The range of concentration, how far or how wide in the analytical measurement range do we use? Number of sample use, experimental design and statistical analysis, as well as the resource intensity available to our laboratory for this activity. So just to give an example on the commutability issue, these are two different sets of results, one produced using patient samples and one produced using quality control materials. And you can see that imprecision measured using patient samples are higher than when we measure using quality control materials. And this can, for example, be due to the fact that quality control materials are simplified matrices. Yeah? We take away things, we modify it so that it has longer shelf life, it's more stable, and in the process, it may constitute a more simplified matrix compared to human samples. But the converse can be true that we mentioned earlier, right? So for example, this is again two sets of data, one from patient samples and then one based on QC. And we realized that for one of the measurement procedure or manufacturer, the bias is significantly much higher using QC material compared to when using patient data. So what are the common ways of us performing lot-to-lot verification statistics-wise? We can use the difference-based approach. So you have the old lot, the new lot. You either compare individual concentrations, can be 3 to 5 to 10 or 20. We could look at the overall mean difference across the different levels or different concentration. We could perform a t-test to determine whether there is significant difference between the two lots. We can compare that against a predefined analytical performance specification or commonly in a fixed percentage terms. We can also use regression-based method, for example, checking on the slope, intercept, R or R square. And then there are different types of sample used, either QC material, sometimes we use leftover EQA material, sometimes we use patient materials. The number of samples as well as replicates have an important implication on whether we are able to detect the lot-to-lot change. So my colleagues and I actually studied this quite extensively. We did a large simulation study on this involving several hundreds of scenarios. And you don't have to read the entire article or the statistics behind it, but these are the 8 sort of take-home message that we come out with after going through the massive simulation exercise. And they are, first of all, we should, as laboratory practitioners, determine what is the desired false rejection rate and probability of bias detection, right? So like what Tony said, you have to know what you want to detect and what you're willing to accept as a false positive rate before you can actually design your study or your experimental design statistics as well as criteria for it. If you use arbitrary rejection criteria based on regression, slope, intercept, or coefficient, most commonly we say slope 0.9 to 1.1, for example, right? R squared 0.95 or R of 0.95. These are random criteria that have no scientific basis. They often will lead to poor error detection and high false rejection rate, okay? So for measurements with narrow measurement range, i.e. the minimum to maximum is a very narrow range. For example, you have sodium or potassium. And low imprecision, again like sodium or potassium or total protein or albumin. T-statistics is the preferred approach, yeah? Do a t-test in order to detect whether there is significant difference. For others, you can use the mean percentage difference across the different concentration. For laboratories with modest resources, meaning that if you don't have a lot of resources to perform lot-to-lot change or lot-to-lot verification, we feel the minimum that you can perform is 5 samples measured in single replication, or you can have 3 samples measured in duplicate, okay, across the concentration range. So this is the minimum. Of course, the more you have, the better you'll be able to detect the error and the less false positive you would get, okay? And if you combine mean difference and individual difference approaches, will improve detection, but will incur higher false positive rate, which can be reduced by increasing the number of replication analysis. Small biases coupled with large imprecision inherent in the measurement procedure is going to make them very difficult to detect either way, yeah? Meaning that you have to use some other method to detect it. And when bias is detected by formal statistical evaluation above, it should be compared against a priori defined bias performance so that we can know whether it is actually clinically acceptable or not. And if you use linear regression as your main method or as your preferred method for lot-to-lot reagent verification, this is yet another simulation study that we've performed previously. These are some of the take-home messages, yeah? Use weighted form compared to non-weighted form. You can refer to the manuscript for the details. Weighted form basically just adjusts for the variance across the concentration range. Laboratories should determine the desired power of bias detection and tolerance for false rejection, as mentioned earlier. Use appropriate number of samples and replicate that fulfills the requirement. In general, again, 5 samples measured in singlicate has poor statistical power for bias detection and should be avoided when using regression approach, okay? So measurement procedures with high imprecision may require high number of samples and or replicates that may not be operational practical to achieve in the laboratory. So this is the cumulative drift effect. Just to show, these are the lots that my laboratory in NUH has accepted. But what you can see is that the patient results over time actually drifted downwards because there was a small lot-to-lot drift that we keep accepting between the lots. And we have therefore developed a statistical method that allows us to track the small drift, the lot-to-lot difference, over time to see whether there is presence of cumulative drift or not. So what are the other potential solutions? Improving transparency of lot evaluation with the manufacturer. So if they can inform us of how they actually evaluated, what are their criteria, they will in turn inform us of how we should actually consider those lots. Harmonized acceptance criteria between regulators, manufacturers, and users. Networked laboratory approaches. This is something that I feel we don't do enough, right? So if individual labs, we don't have that much resources, why can't we pool together our resources? If we all use the same manufacturer, we are going to undergo the same reagent lot change. The few of us can do a little bit, and if we pool our data, the number is going to be very big. And it will actually be very useful for us to have a lot of confidence in saying whether there is indeed a lot-to-lot shift or drift, or indeed change in their imprecision. And then we will incur much less false rejection rates. Yeah. We can use commutable EQA or proficiency testing, patient-based monitoring or quality assurance, post-market surveillance and regulations by the regulators to help tighten the process. This is just one of the methods that we've developed to deal with increased imprecision after a lot change, which uses patient-based quality control principles. So this is an example of how patient median may be used to monitor lot-to-lot change, and this is by Noklas from Norway. And it is an evolution of their older program called Percentiler and Flagger program. And what it does is it takes in the daily median from the laboratories and just trend it across time. Yeah? And if you give your reagent lot information, then you can actually see whether there had been any drift or shift in the performance. The same way I showed you the sodium results previously, that you would see over time there may be systematic drift downward. And if you pull all the different labs that uses the same laboratory method across different reagent lots together, you may indeed also see whether that particular method group as a whole are moving in a certain direction due to lot change. So these are the references that I used for my talk, and thank you very much.
Thanks very much, Siping.
No questions?
One question so far. Yeah, any questions if you wanted to log them now, thanks. Is this one?
LTLV can be performed either component or... What's LTLV? Lot-to-lot variation. Can be performed either...
There's one under there as well after that one too.
Okay. So the question is, can lot-to-lot variation or lot-to-lot verification be performed either comparison between old and new lots or according to CLSI EP 26? I'm not particularly sure what, do you know what they are trying to get at?
I think they're referring to a CLSI standard. I'm not familiar with that.
Yeah, so so the person who provided this comment, either if you would like to clarify, if not, then I will try my best to address it. It's okay, I can get it, thank you. I can try to address it, but these are, so the reason why we performed this simulation study was because we found that these are the common ways that laboratories actually perform their lot-to-lot verification. I'm not, in this particular moment, I'm not particularly familiar with CLSI EP 26. Without referring to the document, I don't really know the title. But essentially, most of us either perform it by comparing the difference between the old lot and the new lots, or based on regression approaches. And certainly, these different approaches actually have different limitations depending on the measurement procedure itself. For example, the concentration range as well as the imprecision of the assay. Yeah? So based on those few different properties, there are different experimental designs as well as statistical analysis that are optimized, that can be optimally used to detect the lot-to-lot variation. The use of a blanket protocol, which is very common in most laboratories. So in most laboratories, we just use one lot-to-lot variation procedure, right? Verification procedure for everything. To be honest with you, that is likely to lead to suboptimal performance in most scenarios. Yeah. So if you have one that fits everything, what you may find is that for most of it, you would accept it all the time, because it's too wide or it's not sensitive to the bias, for example. Or you may find yourself rejecting the lots a lot of the time, and then you go into an argument. Okay, should it be an argument? Should be an intense discussion with the manufacturer over a lot that you think is faulty, but they claim that it's actually perfectly fine, right? So the problem with not choosing the optimal experimental design and statistical methodology is that you would either incur high false positive and or high false negative, both of which are not particularly helpful for routine practice, and then you may find yourself using a lot of, wasting a lot of resources to try to address something that are phantom, that are not there.
That was an earlier one.
Okay.
CBC test.
So there was another question about full blood count tests are more stable than other biochemistry tests. How significant lot-to-lot variation or verification can detect any drift shift in patient results? I must say that I'm not a hematologist. I'm only familiar with biochemistry. So if we think that that method is, so first of all, the question I would ask myself is, if you say full blood count is stable, what is it premised upon? Is it premised upon QC and EQA, or is it premised upon patient data, right? Because we've seen that QC and EQA may have committability issue and may not actually give us the full picture. And when you say stable, what kind of criteria were you using? If you have a very wide criteria, and therefore you say that it's stable, in reality, if you look back at the patient results, you may find that they are drifting away. So if you tell me that it's stable, my preference is actually to look at patient results to show that it's actually stable.
I think that's a similar question.
Yep. And even if it's stable, I would still recommend that we do lot-to-lot verification, because in the example of the mass spec methanol example, sources of variation can come from places that you don't really expect, and if you don't perform lot-to-lot variation, or if you don't perform monitoring of the patient results, you may actually very easily miss it. So a lot of us are lulled into the sense of false security, thinking that things are stable and things are fine. But as mentioned by the previous speaker, if you don't know what you're looking for, you won't find it, right? So if you don't specifically look for it with the right criteria, with the right methodology and the right design, you may miss it. And even in my laboratory, as I showed earlier, right, we are guilty of that. We are guilty of allowing lot-to-lot variation that has been accumulating across time to happen simply because of the way we are performing it and the criteria that we were using it. And you could argue that just by looking at this side, on the left side, things are rosy, right? It's actually fulfilling our acceptance criteria and things like that. And therefore, we accepted the lot-to-lot change. But if you look at the patient results, then undeniably there is a consistent downward shift across time. Yeah. Thank you.
Okay. Thanks, Siping. Can I ask one other quick question, without being too controversial? What if there's no other number available? Would you ever use factors?
Say that again?
If you've identified a lot-to-lot variation, if there's no other lot number available at that point in time, would you ever consider factors?
So that is a really interesting question. So if you find significant lot-to-lot change, right, and you don't have any other lot numbers, any other lots to use, and this is indeed a practical problem that we get in our laboratory as well. The manufacturer may tell us that, hey, you know what, I give you 3 different lots and you say all 3 different lots are lousy, and we don't have any more reagent lot, deal with it yourself, right? So first of all, you either accept it or you reject it and you shut down your service. How you deal with it depends on the philosophy of the laboratory and where you stand. There is no fixed answer. You could shut down your service because if something doesn't meet your clinical criteria and yet you accept and run it, then what's the point of having any quality criteria at all, right? Or you can reject it, close your service, and then ship it out somewhere else. But think about the risk and benefit. If you shut it down, send it somewhere else, would the transportation incur larger error or not, right? Would the turnaround time be affected such that the patient care is actually affected more than the bias that you've seen? And of course, there's the practical solution that has been raised by Peter. Would you actually consider factorizing it? And that's a practical solution to it. How we apply it, how we derive the factor is very important. And we've done a simulation recently to show that how you should actually perform that. And then once you have it in, how you manage the factor is very important. Because you may forget to take it out, you may leave it there indefinitely, or you may key it in the wrong way, such that it may cause error. So again, look at your lab, look at your clinical philosophy, look at what you think will cause the least harm, and then proceed with that option. Thank you.
Thanks, Siping.